Hello, my name is Corey Shields, and today I will be presenting on patient safety incidents related to income. As an overview, let's take a look at our objectives. The objectives are to investigate whether communities with lower median household incomes experience higher rates of preventable patient safety incidents using the PSI 90 composite score. We have several data sources where we combine CMS hospital safety data with the United States Census Bureau income data, and we're going to join those data sets via a zip code for geographic alignment. Our methodology is going to utilize Python for data preparation and integration, statistical analysis, and regression modeling conducted in SAS Studio to explore income safety outcome correlations. The impact We're aiming to reveal income-related disparities in patient safety and support evidence-based healthcare policy improvements for underserved communities. With looking at our research questions and hypothesis, health inequity persists in the United States, disproportionately affecting low-income populations with reduced access to quality care and worse health outcomes. Health equity is defined as the absence of disparities in health across social, economic, and demographic groups. Our initial observations suggest a correlation between median household income by zip code and the frequency of patient safety incidents reported by CMS. This study explores whether low-income communities are at greater risk for adverse healthcare events. So are lower income areas more likely to have higher rates of patient safety incidents? When looking at the literature that has been performed already, we see with regards to socioeconomic status and health outcomes that lower income education levels strongly predict poor outcomes, higher hospital readmissions, chronic illness, and mortality. Barriers to preventative and high quality care in low income communities lead to increased patient safety risks. Long-term economic hardship also contributes to systemic healthcare disadvantages. With regards to hospital quality and resource disparity, understaffed and under-resourced hospitals are more prone to safety incidents such as infections and surgical complications. Medicare data also shows higher 30-day mortality for patients from deprived neighborhoods treated at low-rated hospitals. Community socioeconomic status and hospital quality combine to impact patient outcomes. When we're measuring the deprivation accurately, the balanced area deprivation index is what was utilized with the BADI is the acronym for that, improving on traditional socioeconomic indices by refining metrics to better predict adverse outcomes. BODI also shows stronger correlations with Medicare patient risks than previous tools. Utilizing geographic information disparity in the literature, the Area Deprivation Index links zip code level socioeconomic status to higher hospital readmissions and adverse events. Mapping PSI 90 data with ADI income data highlights areas of geographic health risk. So why does PSI 90 matter? Well, PSI 90 is a key national benchmark for hospital safety performance. It's publicly reported and linked to Medicare reimbursement and also includes location data. Studies show income disparities persist in PSI 90 scores even after adjusting for hospital level variables. So let's look at these data sets. So the PSI 90 data set is a composite indicator of preventable adverse events in the United States. And this data is derived from a publicly available CMS Medicare data website, and it captures hospital level safety performance. Looking at the Census Bureau income data, this provides us with a median household income by zip code and offers us the essential context for assessing socioeconomic status at a local level. So why would we even use this data? Well, both are trusted, publicly available sources with consistent geographic identifiers. They align directly with the research objective and explore the relationships between income level and patient safety incidents. CMS data reflects hospital outcomes, while census data reflects community context, enabling correlation analysis by location. Combining PSI 90 with median income data allows for a location-based analysis of how socioeconomic disparities may impact safety outcomes. So what were our findings? Well, we utilized descriptive statistics to explore distributions of PSI 90 scores and median income. The linear regression was used to model the relationships between an independent variable of median household income and the dependent variable of PSI 90 composite scores. The assumptions tested to ensure model reliability, including linearity, normality of residuals, and independence of residuals. Looking at our regression model, we can see that there was a statistically significant negative relationship between median income and patient safety incident rates. With a p-value of 0.001, this is strong evidence of a relationship. However, the R-squared value was rather low, so the low explanatory power limits practical use as a standalone predictor, with the median income explaining less than 2% of the variation in PSI 90 scores. So with this, higher income communities are less likely to experience adverse patient safety effects. Despite significance, income alone is not sufficient to explain the differences in safety outcomes. So what are our conclusions? Well, we have some key takeaways. A statistically significant inverse relationship exists between median income and patient safety incidents. Patients in lower income zip codes are more likely to experience preventable hospital safety events. With the low R-squared value, we underscore that income alone is not a strong predictor, but an important contributing factor, and this highlights the structural inequalities embedded in the United States healthcare system. There were some limitations in our study. Limited variables at the hospital level and demographic factors not being included. Truncated income data may also have reduced the precision, but that is what was provided from the Census Bureau. And this reinforces the need for a multifactorial model in healthcare equity research in the future. Healthcare organizations should include socioeconomic data in quality improvement and risk adjustment. Future research should incorporate variables like hospital staffing, demographics, and access to care. Policy efforts should target resource allocation for hospitals in economically disadvantaged areas. Public health IT should develop predictive tools using income and social risk data to flag high-risk communities. And our final thoughts, advancing health equity requires both data-driven insight and system-level interventions that account for the social determinants of safety and care quality. Thank you all very much. I appreciate you listening to the presentation, and I hope you learned something.